Every year, thousands of eye doctors give myopic children prescriptions for single vision lenses. And in every modern clinical trial we have, that lens is the treatment that loses. In these pivotal trials, the modern myopic control lenses cut a child's myopic progression by 48 to 67%, which means single vision lets the eyes progress 2 to 3 times faster than it had to. I'm going to give you my entire thesis up front. Single vision lenses should no longer be our default prescription for the average myopic child. Myopic control lenses should not be a premium upgrade we offer when a family pushes for it. They should be the default as we move away from the weaker disease controlling option. For the rest of this video, I will prove that is not an overstatement. This is not a talk about a new treatment. The treatments already exist and some are FDA approved. Most importantly, the treatments work and work well. This talk is about a standard of care that has not yet caught up to the body of scientific evidence, about changing that standard of care. I'm Dr. Robert Clark. I'm a clinical associate professor at the Stein Eye Institute, UCLA, and a pediatric ophthalmologist and owner of South Bay Family Eye in Long Beach, California. For disclosures, I consult for CooperVision for the MySight contact lens and for Viluma and Synexus for low-dose atropine eye drops. This video is not about those treatments. It is about the myopic control results that every modern myopic control spectacle lens reproduces. One distinction before we go further, because it is the entire frame. A treatment is what you do for the one child in your chair, the right drop, the right lens, and your clinical judgment. A strategy operates on the population. What do we train eye doctors to do, and what the optical shop dispenses when no one specifies otherwise? I am not here to educate you on how to treat a myopic child. I'm here to change our default, because that default is how we are failing an entire generation, one single vision prescription at a time. Here is the menu of treatment options. Two are FDA approved, the Essilor Stella spectacle lens and the CooperVision MySight contact lens. And there's a robust toolkit of off-label tools supported by clinical trial evidence, behavior modification, low-dose atropine, orthokeratology, and emerging red light therapy from Asia. The one thing we're saying about all of them is that optically with the lenses and pharmacologically with atropine, they converge on the same effect, changing the eye's abnormal growth signal so the sclera stops its pathologic elongation. The goal is not simply to clear central image blur, the way a single vision lens does, but to prevent the future worsening of vision. And remember this, the FDA, an agency that has lagged the published literature on myopic control for years, has already cleared two of these treatments on the same mechanism. That is the highest tier evidence medicine offers. The literature isn't ambiguous. Even the government regulators are starting to catch up. Now, the objection I hear more than any other is, shouldn't we get these kids off their devices before we start myopic control treatments? It sounds responsible, but it is wrong on two counts. I want to dismantle both. First, the dose is wrong. If near work drives myopia, the heaviest near work load in a child's life is not the phone. It is schoolwork, followed by sustained intensive reading. Those are the highest dose exposure we have. And you cannot write a prescription that says, stop doing schoolwork. Singling out screens feels virtuous and targets the wrong exposure. Second, the track record is damning, and we already ran the experiment. The AAP has already issued behavioral guidelines. Look at what happened next. Childhood obesity rose 52% after the guidelines launched. Global child myopia rose 35% after the guidelines launched. Advice that depends on children changing their behavior against the pull of their environment does not bend the disease curve. It never has. Yes, outdoor time carries a genuine signal, but it acts mostly on onset, on whether a child becomes myopic, not on slowing the disease from the myopic child already sitting in your chair. And it scales no better than any other physician advice. So what has protected children? Not nagging them to get off their devices. Engineering. Car seat mandates dropped childhood traffic deaths by 83%. Helmets and face shields in junior hockey cut eye injuries by 52%, and not one injury occurred in a child wearing protection. Every durable win in pediatric safety came from a passive intervention, one that works whether or not the child cooperates, whether or not the parent remembers the doctor's advice. That is exactly what a myopia-control lens is. Your child already wears glasses. You simply change which glasses, and the pathologic growth signal changes with them. No willpower, no compliance battle, no behavior to modify. The defocus lens is the car seat. Cut down on screens is the advice that has never once worked at the population level. If you believe passive prevention has worked anywhere else for childhood safety, you should believe it will work here for myopia control. Which brings us back to the lens itself. Let's name it plainly. The single vision lens is the problem. It is safe, but only in the shadow resistant sense. It is effective, but only for clearing central image blur. Against the disease, against myopia progression, it does nothing. And nothing is generous, because we now know the mechanism that creates harm. Single vision optics impose hyperopic defocus onto the peripheral retina, an optical growth cue that tells the eyes to keep growing longer. So when an eye doctor says blaming regular lenses for myopia progression is too big of a leap, understand what's being claimed. This isn't blame. This is the optical physics of the lens we prescribe by default. The single vision lens is not neutral. It is the placebo option that, in clinical trial after clinical trial, always loses. I preview this number at the top, so let me pay it off in full. Here are 4 pivotal trials. Stellest cut progression by 67% versus single vision. MyoSmart, 59%. SightGlass, 59%. MyoCare, 48%. 4 manufacturers, 4 different optical designs, at least 2 distinct mechanisms, and 1 unanimous verdict. The single vision arm is always the placebo, and it progresses 2 to 3 times faster than the active myopia control arm. This is the part I want to sit on, because it is the most reproducible result we have. The comparator loses every single time, no matter who engineered the lens or whatever the putative mechanism of action might be. When 4 competitors using 4 different optics arrive at the same verdict against the same control, that control is not a neutral baseline. It is the worst option in the room. For the average myopic child, there's only one question that matters. If you keep prescribing single vision, why? What is your treatment rationale for why that lens is the best option for that child? We have lived through this exact pattern before. Anti-lock brakes were invented in the 1970s. They didn't become standard, along with electronic stability control, on every vehicle until 2007. That 35-year gap, the gap between it works and it's standard, cost roughly 150,000 preventable lives lost and 9 million preventable injuries. The technology was never the bottleneck. Inertia was. We should not wait that long to switch to this safer lens technology. And notice the shape of that delay. Anti-lock brakes spent years as a premium upsell, a feature you paid extra for in luxury cars. Today they're in every car, mandatory, no longer even mentioned in advertising. Myopia control lenses are in that premium phase right now, marketed as a pricey upgrade. The only open question is how many children we make wait until the premium option becomes the standard option it is destined to become. And that future is not speculation. It has already arrived. Multiple approved optical designs are available worldwide. Competition is collapsing the premium. In Italy, the price differential over single vision is down to about 50 euros. In France, these lenses are now covered by state-sponsored insurance, with a price cap of about 150 euros per lens. And internationally, the consensus is already walking away from single vision lenses for myopic children. The United States is not leading the shift. We are lagging the rest of the world. Now the cost objection. Another big complaint I hear from my doctors. The lenses are too expensive to recommend. 3 answers. First, the premium will shrink and insurance coverage is coming. The too expensive framing will soon be out of date. Second, and this is the part to think about, single vision is the expensive choice. You're not saving the family money. You are deferring the bill. Progressive myopia carries real lifetime costs. Each diopter of progression raises the risk of uncorrectable vision loss by about 40%. How much is too much to pay for the best chance at a lifetime of clear vision? Third, don't prejudge the parents. It is not your job to decide what they can and cannot afford. Offer each child a better option as a default and let the parents choose. In my practice, parents across every income bracket want the best care for their child. Cost can be a reason for an opt-out. It should not be the reason you quietly prescribe a child the worst lens. You pay for myopia control during childhood. You pay for high myopia for life. So what actually changes in your clinic? Less than you fear. Today, the myopia-control lens is the opt-in premium upgrade. You spend extra time persuading a family to accept the better option, while the single vision prescription takes seconds. The weaker choice is the easier choice, and that asymmetry, that friction is the entire reason we keep defaulting to harm. The path of least resistance runs straight to the worst lens. So flip the script. Make myopia control the default prescription for a myopic child. The optical shop dispenses it unless you specifically write single vision. Now the routine visit ends with a straightforward recommendation. And the only conversation you have is with the family that chooses to opt out. You are no longer selling an upgrade. You're explaining the downsides of opting out, why the weaker option will likely lead to worsening vision for their child. And a parent of a newly myopic child, especially a myopic parent watching their own history repeat, is often carrying real guilt. We want to bless our children with our best traits and spare them our worst. Giving parents an effective treatment does not add to that parental guilt. It relieves it. It turns a powerless diagnosis into a plan. It makes the parent your partner in bending their child's myopia trajectory. The action that should make us uncomfortable is the opposite. Dispensing the inferior lens and waiting for the eyes to get worse before we act. Let me make an important clarification. A default is not a mandate. Not every child gets the same lens in every circumstance. Cost, binocular status, a specific clinical problem, those are real exceptions. Exceptions don't change the default. They're the reason we document them. We set defaults for the population, and we make exceptions for the individual. That is how every standard of care medicine already works. No one is taking away your clinical judgment. We're just changing where the burden of justification sits. And right now, it sits in exactly the wrong place. I want to end with one of the most famous examples of how a simple change in doctor behavior, completely independent of patient behavior, create a profound health benefit. In 1847, Semmelweis implemented hand washing in his maternity ward and dropped maternal mortality from 18% to 1%. He proved that hand washing saved mothers' lives. And yet, the medical profession resisted his advice for decades while women kept dying. Not because his evidence was weak, but because accepting it meant admitting that current practice was causing preventable harm. I am not saying single vision lenses are the same as unwashed hands. But the circle pattern is familiar. Doctors are slow to change their default behavior. Multiple randomized trials show 48 to 67% reductions in my progression, and we keep prescribing single vision out of habit. There comes a point where the current comfortable default becomes the risk. We are at that point. The single vision lens has become the risk. This is why pediatric ophthalmologists should lead this change in clinical practice. If we do not define the standard, the marketplace will define it for us, lens by lens, family by family, and optical shop by optical shop. A specialty recommendation does not need to mandate one product. It needs to define a default. When a myopic child needs spectacles, the starting recommendation should be an evidence-based myopic control lens, and single vision should be chosen deliberately for a documented reason. So the path forward is straightforward, and it involves 3 steps. Update what we teach our residents. Normalize myopic control optics into routine everyday practice, and stop treating single vision as the default choice for a myopic child. If you want an honest test for any of this, use the one I use on myself. If the child in your chair were your child or your grandchild, would you send them out the door with a lens you know doubles their mild progression just because it's the easier, cheaper prescription to write? I think you already know your answer. You would never accept that risk for your own family. The only question left is whether we're willing to stop accepting it for everyone else's children. Are we ready to change that default? Here is a proposed standard of care for your consideration. I'm Dr. Robert Clark. Thank you for your attention.